Uh, yes, good evening and very warm welcome to each one of you for this exciting Friday evening session on insulin resistance and the details. It's our pleasure to have all of you with us. And myself, Dr. Mayur, I welcome all of you again on behalf of Alchem Metabolics team for this exciting session today. The topic for today is break the insulin resistance and make an impact with the triple drug combination of sitagliptin, metformin, and pioglitazone, which is recently launched in Indian market by Alchem Laboratories. To decode the mystery behind the pathophysiology of diabetes, the role of insulin resistance, and the various factors associated with that, we have none other than Professor Ralph today. Professor Ralph, thank you so much being with us, and we really look forward to hear from you. He is Professor of Medicine and Chief of Diabetes Division of University of Texas in Texas. He is the person who has worked extensively in this area of insulin resistance, and he has received many accolades, national and international level. Especially, we talk about the Banting Award from ADA in 2008 for his discovery of ominooctate, and he has several publications in the space of diabetes to his credit, and he's the astute teacher and a mentor for many clinicians across the globe. So welcome, Professor Ralph.
Pleasure to be here.
Yeah, and from our own country, we have three esteemed speakers today, which will be participating in the panel discussion in the later part of the presentation today. So we have Dr. Vinayak Harle from Pune. He's a endocrinologist from PD Hinduja National Hospital, Mumbai, and he has practiced currently in Pune, have several publications to his credit in national and international journals, and has given various orations in various conferences. Dr. Vinayak, very good evening to you, and thank you so much for being with us. Then we have Dr. Subrata sir from Kolkata. He's a gold medalist and consultant at Desun Hospital and Medical Super Speciality Clinic in Kolkata. He has authored an article in textbook of RSSDI on the monographs of insulin, the manual of lipidology. He has published various articles in national and international journals in the space of diabetes and has given several orations in various conferences. Welcome, Dr. Subrata, and thank you so much for being with us. And lastly, we have Dr. Himanshu Sharma from Delhi. He's a consultant endocrinologist and assistant professor at Rajiv Gandhi Super Speciality Hospital in Delhi. He has several papers to his credit, and which he has published in various astute conferences, and he has publications of national and international repute to his credit as well. So, Dr. Himanshu, welcome, and we'll hear from each one of you in the later part of our discussion. So, with this, I conclude my introductory speech and the context setting. I would like to hand over this session to Professor Ralph himself and giving a speech on insulin resistance and possible role of this triple combination in the space of diabetes. Over to you, Professor.
Great. Okay, if you can put my slide up, that would be great. Now I just have to figure out how can I clear the middle of the screen with everybody's faces. So I have...
You can first probably put your slide, sir, in the share button. You can click the green button where it will pop up as multiple screens. You can select the screen which you want. Yeah, indeed, it's visible. And you can minimize the different faces which are...
there we go. I got it.
Perfect.
Miracles. Perfect. Thank you for helping me through that. Okay, so it's a great pleasure for me to be with you this evening, this morning here in San Antonio, Texas. And so we're going to talk about the ominous octet in terms of what the implications are for treating people with type 2 diabetes. I've always been a firm believer that if you understand what causes a disease, you'll be much better equipped to provide the most effective therapy for your patients. And let me just make sure I can make this screen go. There we go. So these are some data that I took from actually the national fact sheet about diabetes in India. You can see it's a huge problem in your country. 77 million Indians, that's 9% of the population in India. And one of the alarming concerns is that half of all these people who have type 2 diabetes are undiagnosed, and that means that the complications are setting in long before you see them in the clinic. And India contributes to 1 out of 6 diabetic patients worldwide. And I think in terms of sheer numbers, India ranks only second to China. And I think everybody is well aware of the fact that cardiovascular disease is a huge problem in our diabetic patients. And there's a 2.5 to 3-fold increase in the risk of MI, stroke, and mortality. Now, how well are we doing in terms of A1C control? These are data that I actually have taken from the US market. You are probably more familiar with the data in India. I actually couldn't find these numbers as I went on the internet, but I'm quite certain that the data here are very similar to the problems that you have to deal with in India. So if we go back to the year 2000, we're going to look here. There's the percentage of participants, the white line, who have an A1C of 7. Well, you can see we see a significant improvement in the early 2000s, but we've kind of dropped off in the last 5 to 10 years. And half of the people in the United States have an A1C above 7, which means we're only, controlling 50% of our diabetic patients type 2 in the US. This yellow curve is a little bit more disturbing. If we look at people with type 2 diabetes who have an A1C less than 8, you can see over here in year 2018, it's 75% of the people, which means that 25% of the people have an A1C above 8. And of course, these people are at incredibly high risk for the microvascular complications, eye, kidney, and nerve damage. So it's very clear that in the United States, and I'm quite certain that the data in India are very similar, we're not really doing a great job of getting the glucose under control. Now, there are many reasons why we fail, and these reasons are the same in India. We use the treat to fail approach, and I've been a person who's spoken against this for over 20 years. We put people on the first medication, and then we wait till they fail. And then when they fail and their A1C reaches an unacceptable level, we add the second drug. Yeah, there's an initial good response, and then there's a failure sets in, and then we start the second drug, and then we do okay for a little while, and then things start to fail. This treat to fail approach really is not an effective way of treating our diabetic patients. A second problem is physician inertia. We know that physicians can sit in front of their screen, their computer screen. They can see an A1C that's 8, and they still do not increase the dose of the anti-hyperglycemic medication or add additional medications. Patient noncompliance is a big problem. If the patient does not really take their medication and they don't work with you in terms of dietary compliance, they will always defeat the physicians. We know that the cost of the medications is a big problem. In the United States, we have a bunch of newer medications. We have Ozempic. You don't have tirzepatide yet. These medications are incredibly effective, but they cost $1,000 to $1,200 per month. And most of my patients cannot afford the cost of these new medications, even though they're very effective. And perhaps the most difficult concept to get through is that diabetes is a very complex disease. We're going to talk about the pathophysiology. And if you don't use drugs that correct the underlying pathophysiology, you're not going to be very successful. And because we have multiple pathophysiologic disturbances to deal with, we're going to need multiple drugs in order to get our diabetic patients controlled. So this is an example of the treat to fail approach. The hemoglobin A1C is plotted on the y-axis, and this is schematically time on the x-axis. And you can see we start the first agent, we get a nice drop. If you look at the dashed white line, we get a very nice drop in the A1C, but then you can see it starts to rise again. And then we add the second agent. We get an initial response, but then failure, third agent failure, then the patients end up on insulin. Now, this slope was first defined in the United Kingdom prospective diabetes study. There's about a 0.75% rise per year over the first 5 years. And interestingly, in the ADOPT study, which is a more recent study carried out by Stephen Kahn, this rate of failure was identical. So in fact, over the 30 years between the UK PDS and the ADOPT study, we really haven't changed the natural history of type 2 diabetes. Now, why is good glycemic control important? So I'm going to use the diabetes control and complication study to make this point. So the DCCT study was a study of intensive insulin therapy in type 1 patients. Very large study. Half of the group, and the people started with an A1C of 9. Half of the group were maintained on their usual insulin doses. You can see here in the yellow line, the A1C stays at 9, not very well controlled. The intensive group got multiple split insulin regimen, or they got insulin pump therapy. You can see a very nice drop in the A1C. And over this first period of 8 years, they're very well controlled. Now, the study ended at year 8. Now, the people who were in the conventional group said, you know, we feel like we were cheated. We should have gotten the more intensive therapy. And so they, out of their own intuition, they improved their glycemic control. The people who were in the intensive group said, wow, this was pretty tough. We can't keep this up. And their control got a little bit worse. And you can see after the first 8 years, the A1C came together. So what I want to do is to focus on this first 8 years here, after one group is poorly controlled and the other group is very well controlled, but now their A1C comes to the same level. So over those 8 years, and that's plotted down here on the y-axis, let's look at the cumulative incidence on the left of progression of diabetic retinopathy, the conventionally treated group in yellow, the intensive treated group in orange. And you can see, despite the fact that they have identical A1Cs during this period, that initial 8-year period of good glycemic control made a big difference in the intensive group, and they had a lot less diabetic retinopathy. Even more impressive are the data if we look at renal disease. And for this marker, we're going to look at clinical albuminuria, and we're going to define this as greater than 300 milligram per 24 hours. So this is macroalbuminuria. This is very serious increase in urine albumin excretion. Well, you can see the progression of albuminuria in the conventional group and really a relative plateau in the intensive group. So even though over the next 8 years, these two groups have the same A1C, huge difference in the rate of albuminuria, saying the earlier that we control the A1C and the better we control it, the less likely we are going to see the microvascular complications, in this study, retinopathy and nephropathy. Now, most recently, we've seen the publications in the New England Journal of Medicine of the GRADE study. So what was the GRADE study about? It's a very large study carried out by the National Institutes of Health over some 5,000 individual patients, and they wanted to know what is the best therapy after metformin. So first point I want to emphasize is that metformin failed, okay? So metformin is a good drug, but on a long-term basis, it really is not going to control the A1C. So they wanted to know, look, if we have patients now who are on metformin and they have an A1C that's above 7.5, which is the best drug to add? So one drug that they chose was glimepiride. That is in white. You can see there was a very nice drop in the A1C, but then progressive failure over the next 5 years. That's nothing new. We knew this from many, many studies in the past that sulfonylureas don't work on a long-term basis. Okay, second drug that was added was a DPP-4 inhibitor. Here they use sitagliptin. Again, we see a drop in the A1C, but again, progressive failure. And then somewhat surprising to me was glargine. I would have thought that if the doctors did a good job of titrating the insulin, they keep the A1C down. In fact, the glargine insulin group failed as well, indicating that even though there was a strict algorithm that they were supposed to follow, the doctors didn't follow the algorithm as intensively as they should. And the one drug that was very surprising to me, I thought this actually would do the best, is liraglutide. The GLP-1 receptor agonists are sort of the newer drugs, and they are very effective, at least we thought. But at least this particular GLP-1 receptor agonist didn't do any better than the other 3 drugs. So what this says is that if you're going to use this stepwise approach, you've already failed on metformin. Now let's pick the second drug. You're going to fail. So it's telling us that this approach, start with drug 1, add drug 2, add drug 3, is not going to be a very effective approach. And it just, I think, adds further emphasis to the fact that we need to start with multiple drugs right from the beginning. And the reason why we need to start with multiple drugs right from the beginning is very clear from my Banting lecture in 2008, which was titled From the Triumvirate to the Ominous Octet. So when I gave the Lilly lecture and that's the Young Investigator Award lecture, I just titled it The Triumvirate. We knew that there was insulin resistance in the liver, in the muscle. The insulin resistance in the liver led to overproduction of glucose throughout the sleeping hours. And this is what causes fasting hyperglycemia. Insulin resistance in the muscle, the diabetic wakes up in the morning, has breakfast, lunch, dinner. The glucose that's in the meal is supposed to be taken up in muscle. The muscle's resistant. You get post-meal, postprandial hyperglycemia. And then, of course, what determines that your A1C is going to rise in the presence of insulin resistance is progressive beta cell failure. So that was a very, very simple understanding of the pathophysiology in the year 18, in the middle of the 2008 or so a year. But now what happened? Okay, here's the Banting lecture. In the upper right, you see here the fat cell. Initially, the fat cell is your friend. You overeat, you take in excess calories, and you put those calories in the fat cell. As long as they stay there, they can't hurt you. But if you keep eating and the fat cells get too big, you become insulin resistant. You start to break down the fat, you release fat to the bloodstream. Elevated FFA levels impair insulin secretion. They cause insulin resistance in the liver, insulin resistance in the muscle. In the middle here at 12 noon is the gastrointestinal tract. Every time you eat a meal, you release 2 incretin hormones, GLP-1 and GIP. These 2 incretin hormones go to the beta cell, and they account for some 70% of the insulin you release during a meal. The K and the L cells, which are responsible for secreting the GLP-1 and GIP, do their job. They secrete sufficient amounts of these incretin hormones. The problem is your beta cells are very, very resistant to GLP-1 and GIP, and they are in large part responsible for this defect here at the level of the beta cell. And of course, we have a treatment for this. What we do is we give back a pharmacologic dose of GLP-1, and we have a number 1 of these a number of these injectable GLP-1, and we actually even have some oral GLP-1s. Here at 9 o'clock is the alpha cell. Alpha cell overproduces glucagon. This excess glucagon drives hepatic glucose production. This is the cause of the rise in the fasting glucose concentration. And many years ago, studies from our group showed that the kidney also takes a part in this pathophysiologic disturbance in people with type 2 diabetes. So in URI, there's a threshold at which, below which no glucose appears in the urine. And that threshold is about 180 milligram per deciliter. But when you exceed that threshold, all of the glucose that's filtered above that ends up in the urine. It turns out in the diabetic, that threshold is markedly increased and go up to 240, 250, 260. So the diabetic kidney, instead of dumping the glucose in the urine, which is what we want, is holding on to the glucose, exacerbating the hyperglycemia. And then down at the bottom is the brain. And we know the brain plays a very important role in appetite regulation. And there are a number of anorectic molecules that turn off our appetite, and the brain has become resistant to many of these. And the one that we're going to focus on a little bit today is the one that comes from the L cells in the gut. That's GLP-1. GLP-1 is a potent appetite suppressant, but your brain has become very resistant to GLP-1. So now when you think about this, we have 8 problems. And in fact, I could add a couple of more, but I'm not going to for simplicity today. It's going to be very difficult, in fact, impossible, for one drug to reverse 8 problems. So if we think about the treatment of type 2 diabetes in relationship to the pathophysiology, we're going to require multiple drugs if we want to correct these multiple pathophysiologic disturbances. And when we pick a drug, we should be picking medications that correct known pathogenic abnormalities. We shouldn't just be picking a drug that lowers the A1C, but doesn't correct the underlying pathophysiology, because with time, that's going to fail. And then we need to start early. Why? Because with time, there's progressive beta cell failure. And if you start to lose beta cells, then of course, that dictates that eventually you're going to end up on insulin therapy. Now, metformin is a very, very good drug. I actually did the entire drug development in the US. The placebo group at the end of a year really had no effect on the A1C, but in the metformin treated patients, A1C dropped to 7.1. These are drug naive patients. On the right-hand side are metformin addition to people treated with a sulfonylurea glyburide. Again, placebo did nothing. And then you see a very nice drop again in the metformin treated group. So these are 1-year data. Now, in 1995, this was a major breakthrough in the United States because we only had sulfonylureas. So now we had 2 oral agents, metformin and sulfonylureas, and we thought we were, in very, very good shape. But what we soon learned, and I pointed that out to you in the UK PDS study, is that very early on, there was failure to both sulfonylurea drugs and metformin. So here are the UK PDS study, United Kingdom Prospective Diabetes Study. So Dr. Robert Turner, who was the primary investigator, believed that if you took newly diagnosed diabetic patients with an A1C of 7, and you put them on a single oral agent, the A1C would come down and stay down. So there are over 4,000 patients in this study. 1/3 of the patients got what we call conventional therapy, that was diet and exercise. And you can see the yellow line here. The A1C over the 15 years of the study went up progressively. And what he showed is all of that rise was due to progressive beta cell failure. The green curve is the glibenclamide curve. Sulfonylureas bind to the beta cell. They kick out insulin. A1C goes down the first year, but then you can see progressive rise in A1C. If you look at the metformin curve, metformin works on the liver. It inhibits gluconeogenesis. You see a nice drop in the A1C in the first year. but progressive rise in A1C because metformin has no effect on the beta cell. Now, 5 years into this study, Dr. Turner could see in the metformin and sulfonylurea group, the A1C had returned to the baseline. So he published 5 papers: diabetes, diabetologia, okay, BMJ, Lancet, diabetes care. And he said, look, my hypothesis is wrong. I can't keep people on a single oral agent and get them controlled. So if you're on metformin, he added the sulfonylurea. If you're on the sulfonylurea, he added metformin. And then if necessary, he said, I'll add insulin. So this study went on for 15 years. And at the end of 15 years, if you go across, you can see A1C is 8.6. Now, at the end of the 15 years, everybody is on metformin plus a sulfonylurea, and 65% of the people are on insulin. And yet the A1C is still 8.6. Not a very effective therapy. So the UK PDS told us 2 important things. It was the first study in type 2 diabetics that said good control was important. So this separation in the A1C curve between the conventional, the control group, and the SU and metformin treated group decreased eye, kidney, and nerve complications by 37%. And that's what everybody focuses on. But I focus and take home the second message is that metformin and sulfonylureas are not going to work on a long-term basis to control your glucose level. And you are going to need other medications because, as you'll see in a second, if we come back now to the ominous octet, I've listed here where metformin and sulfonylureas work. So metformin works on the liver and it inhibits gluconeogenesis. Many of you have been told that metformin is an insulin sensitizing drug, and that is clearly incorrect. So when we did all of the studies to get metformin approved by the FDA, we used the gold standard insulin clamp study to measure insulin sensitivity in metformin-treated patients, and metformin had absolutely no effect to improve insulin sensitivity. So it corrects one of the problems of the ominous octet. So go around. Where do you see sulfonylureas being used to attack any of these problems? Well, you don't see it anywhere. And that's because on a long-term basis, sulfonylureas don't correct any of the components of the ominous octet. So in 1995, yes, metformin and SUs were the only combination therapy that we had. And initially they worked very well, but not surprisingly, just as UK PDS showed us, on a long-term basis, they really were not all that effective. Now here you'll see a very, very different picture. These are now the 8 long-term studies carried out with the thiazolidinediones, and there are 2 of them, pioglitazone and rosiglitazone. And now you see a very, very different picture. Now, the initial drop in A1C differed because the study designs are very, very different. But whatever that initial drop is, you can see the A1C came down and it stayed down. Now, why did this happen? Everybody, I think, who's listening in knows that the TZDs are fantastic insulin sensitizing drugs. And I actually worked very closely with Takeda Pharmaceuticals in the development of pioglitazone. And we clearly demonstrated the potent insulin sensitizing effect of the sulfonylureas. So at the level of the liver, these drugs improved insulin sensitivity. At the level of the muscle, pioglitazone was a great insulin sensitizer. It was a great insulin sensitizer at the level of the adipocyte. But what we went on to show is the real reason why the TZDs, pioglitazone, work is they have a powerful effect on the beta cell. So now you have a single agent that's correcting the insulin resistance in 3 of the major organs, but in addition is correcting the defect at the level of the beta cell. So the reason why the TZDs are so effective and they drop that A1C and they keep it down is they correct 4 of the problems, 4 of the major pathophysiologic disturbances that characterize the ominous octet. And we also know from the proactive study that pioglitazone is a very good drug to prevent cardiovascular events. So the PROACTIVE study was carried out in Europe, 19 European countries, a large number of patients, 5,238 patients. To get into this study, you had to have a previous MI, stroke, or some kind of cardiovascular event. And you can see here now in PROACTIVE, if you look at the orange curve, which is the pioglitazone curve, the orange curve falls below the yellow curve. So this is the Kaplan-Meier plot to the time of recurrent cardiovascular event, and the hazard ratio was 0.84, meaning there was a 16% reduction in recurrent cardiovascular events. Now, if we look at recurrent stroke, this is an incredible result. There was a 47% reduction in recurrent stroke. And if we look at myocardial infarction, there was a 28% reduction in myocardial infarction. Now, a very good friend of mine, Dr. Silvio Inzucci at Yale, was very, very much aware, particularly of the stroke reduction data. And he and Dr. Kernan went to the National Institutes of Health and convinced them to do a large study, almost 4,000 people. Now, this study is unique because this study was done, you can see here at the top, in non-diabetic subjects. Now, to get into this study, you had to have either an ischemic stroke or TIA within the previous 6 months. What I want you to focus on here is the A1C. The A1C is 5.8%. So half of the people are above 5.8%, but they're non-diabetic, so it had to be less than 6.4. These people with prediabetes. The other half of the people have an A1C less than 5.8. These people have normal glucose tolerance, okay, according to the ADA definition. And they were treated either with pioglitazone or placebo and followed by 4.8 years. And now what you see here is, as opposed to the PROACTIVE study, the pioglitazone, which is the orange curve, is above the yellow curve. And what we're plotting is cumulative probability of disease-free survival. So the hazard ratio is 0.76, indicating that there's a 24% decrease in recurrent stroke in myocardial infarction. And this is now in a population which doesn't have diabetes. So how does pioglitazone exert these potent cardiovascular protective actions? First, pioglitazone activates PPAR gamma, and PPAR gamma actually directly inhibits the atherogenic process. We know that insulin resistance is a major component of the underlying atherogenic process, and pioglitazone, of course, is a potent insulin sensitizing drug. Pioglitazone improves endothelial dysfunction. It leads to the release of nitric oxide. Nitric oxide is the most potent anti-atherogenic molecule in the human body. Pioglitazone inhibits inflammation. In all of the studies that have been published, there's a nice drop in the highly sensitive CRP. It reverses lipotoxicity. It mobilizes fat out of arteries. It mobilizes fat out of the visceral area, mobilizes fat out of the liver. It's the best drug we have actually for treating NASH and NAFLD. It decreases plasminogen activator inhibitor 1. It reduces both systolic and diastolic blood pressure, and it corrects diabetic dyslipidemia by lowering the triglycerides, raising the HDL, and decreasing small dense LDL. So what about the side effects? So there's been a lot of concern that have been raised about the side effects. And these concerns, in my opinion, are in large part due to misconceptions and not really understanding what pioglitazone is doing. So there are 4 that I'm going to touch upon briefly. Weight gain, bladder cancer, which does not occur with pioglitazone, fluid retention, and bone fractures. So let's start with weight gain. So in the PROACTIVE study, there was only one factor that predicted that participants would not die. So what is that factor? I love to give this talk to cardiologists, because if there are 100 cardiologists in the room, probably 100 of them are not going to get the answer. So what is the one factor that predicts that patient's not going to die in proactive? Weight gain. In fact, the more weight you gain, the less likely you are to die. And the more weight you gain, the greater the improvement in insulin sensitivity. The more weight you gain, the greater the improvement in beta cell function. The more weight you gain, the greater the drop in blood pressure. The more weight you gain, the greater the improvement in the lipid profile. So weight gain is, yes, it's a cosmetic issue, but the weight gain is telling you actually that the drug is working. So yes, we don't want our patients to gain weight. Cosmetically, they're not going to like us if that happens, but it's a good indicator that things are getting better. So I like to, again, joke. You have a choice. You can be a little fat and alive, or you can be very thin and dead. So which would you like? I think I'll be a little bit fat and alive, okay? Now, what about bladder cancer? The Food and Drug Administration in the United States asked Takeda Pharmaceuticals to do a long-term study, which was done at Kaiser Permanente in Northern California. There were 193,000 patients with type 2 diabetes who were entered into the study. 1,089 developed bladder cancer. In this study, you can see 137 were treated with pioglitazone, 952 never received pioglitazone. What's the hazard ratio for bladder cancer? 0.98. Remember, hazard ratio above 1 is not good. Hazard ratio below 1 is good. Hazard ratio 1 says nothing is going on. So you can see here in this FDA mandated study, pioglitazone did not cause bladder cancer. Now, pioglitazone in myocardial function, it's very commonly stated that pioglitazone causes heart failure. So we decided to do a study to look at this directly. What does pioglitazone do to the heart? So very commonly, pioglitazone does cause fluid retention and edema. But I'm going to show you it's not due to heart failure, and I'm going to give you and show you the reason why you get fluid retention. So in this study, we took type 2 diabetic patients, and we are going to look at a variety of metabolic parameters, their glycemic control, and a variety of functions of the heart. So at the left, you're going to see before in yellow and after in terms of the A1C. Okay, nice drop in A1C. So even though they start pretty low, 6.7, look, we made them normal, 5.6. What about using the insulin clamp to measure their insulin sensitivity? As we've shown many times in the past, as well as others, a doubling of insulin sensitivity. Pioglitazone, a powerful insulin sensitizer. Now, this is in skeletal muscle. We also, while we were doing the studies, we did them with PET and fluorodeoxyglucose to look at myocardial insulin sensitivity. And look, we doubled myocardial insulin sensitivity. It paralleled the doubling of skeletal muscle insulin sensitivity. And then using PET, we also measured myocardial blood flow, a quite dramatic improvement in myocardial blood flow. That doesn't sound too bad to me, okay? So now let's look at the ejection fraction. This is a measure, of course, of systolic function. The ejection fraction went up by 5%. Does that sound like I'm causing heart failure? It looks to me like I'm doing the opposite, okay? Now, we're going to look at a variety of parameters of diastolic dysfunction. The E over A flow ratio dramatically improved. End diastolic volume dramatically improved. The peak LV flow rate dramatically improved. So all of the measures of diastolic and systolic function show improvement. So why do you retain fluid? It's got nothing to do with the heart. Pioglitazone is a powerful vasodilator, and it releases nitric oxide. Nitric oxide drops your blood pressure, and you underperfuse your kidney. This sends a signal to the kidney to hang on to salt in water. So what people do is they misinterpret the fluid retention as heart failure, when in fact the fluid retention is reflecting the release of nitric oxide, which is a very protective agent. So in summary, pioglitazone causes a durable A1C reduction for up to 5 years. It's a great insulin sensitizer and preserves beta cell function. It enhances insulin signaling. It's anti-inflammatory and anti-atherogenic. It improves lipotoxicity and the dyslipidemia. As I showed you in ProActive and a number of other studies, it reduces cardiovascular events. And I'm not going to have time to take you through this today, but pioglitazone, in my opinion, is the best drug for getting fat out of the liver and reversing NASH and NAFL. Now, what about DPP-4 inhibitors? I'm going to show you some data with saxagliptin to make this as unbiased as I can do it. But if I were to show you sitagliptin, alogliptin, or any of the other DPP-4 inhibitors, the data would be very similar. So if you start with an A1C of 8 and you're drug naive or on glyburide or on metformin or on pioglitazone or rosiglitazone, and then I add here saxagliptin, but the data would be the same for all the other DPP-4 inhibitors, I get about a 0.7 to 0.8 drop in the A1C. Now, what about cardiovascular protection? So that each of these drugs has participated in a cardiovascular outcome trial. And as we go from left to right, this is saxagliptin in the SAVIOR trial, alogliptin in the EXAMINE trial, and sitagliptin in the TACOS trial. And I think if you come down here and look, you can see that the placebo curves and the treatment curves are superimposable. So these drugs are completely safe from the cardiovascular standpoint. They don't provide cardiovascular protection, but in terms of safety, they are completely safe when administering to your patients. Now, I'm going to show you some data. We're going to start to now lead into combination therapy. So this is a study which I carried out with alogliptin and pioglitazone. Dose of alogliptin was 25, pioglitazone 30. And you can see if you look at the decrement in A1C with alogliptin, it's 0.7. With pioglitazone, a little bit more effective, 0.9. And when you put the two together in orange, you get a additive effect. So a good combination. Now, this is a summary slide that I put together of all of the studies in the literature in which a DPP-4 inhibitor has been combined with pioglitazone. So the starting A1C is shown here at the top because you know that the higher the A1C, the greater the drop in A1C with all drugs. So here now is combination therapy. When I add sitagliptin to pioglitazone, I add vildagliptin to pioglitazone. Another set of studies with adding sitagliptin, our alogliptin data. So in all of these multiple studies, and the authors are shown down here in the bottom, you can see you're getting very, very nice reductions in the A1C when you're adding the DPP-4 inhibitor to the pioglitazone. So a combination of a DPP-4 inhibitor with pioglitazone would be a good combination tablet. Now, this is one of the biggest studies that have been carried out. This is Dr. Matthews and Del Prado's study. This is the Verify study. This is a multinational trial looking at combination with metformin and vildagliptin. There were 34 countries, 254 centers, and you can see 2,000 people, and the shaded areas show you the countries in which this study was carried out. So here now, let's take a look at people who are having treatment failure, and we're going to look at the combination of metformin and pioglitazone, and you can see that the treatment failure with this, I guess, green color curve over function compared to metformin and vildagliptin. And you can see that the maintenance of A1C is much, much more efficient in the metformin vildagliptin. So again, here's another combination. I showed you data with DPP-4 and PO. Here's now combination therapy with DPP-4 inhibitor and metformin. Now, overall, the DPP-4 inhibitors are very safe, very low risk of hypoglycemia, no weight gain. They have cardiovascular safety. They're neutral. They don't do anything bad. There's no increase in heart failure risk, and they can be safely administered to patients with renal dysfunction. So if we come back to our ominous octet, these drugs, they don't really increase the secretion of GLP-1 or GIP, but whatever is secreted, they keep it around longer by inhibiting the enzyme that degrades the GLP-1. So you get a modest effect on the beta cell, a quite nice effect to inhibit glucagon, and their major mechanism of action is by suppressing hepatic glucose production. And you can see they have multiple mechanisms of action. So these are going to be a reasonably good choice in our diabetic patients. So the advantages of combination therapy are summarized here, and there are many of them. If you're using a combination therapy, and I'll show you in a second the combination that we've been talking about, you're going to get a very nice early and sustained A1C reduction. With regards to the pathophysiology, the ominous octet, you're going to correct multiple of the abnormalities. If you're picking the right drugs, which are the ones that I just reviewed with you, pioglitazone, in the DPP-4 inhibitor and metformin, there's no hypoglycemia. Because it's a single tablet, this will improve patient compliance. It'll overcome physician inertia because you won't have to be waiting for the physician to add a new drug and titrate things up. And because you can use lower doses, you will improve the safety profile. Although I have to say that the three drugs that we've been talking about, pioglitazone, metformin, and DPP-4 inhibitors are quite safe. Because you have three drugs in one, the cost will be reduced. And because in the triple combination therapy, we're going to include pioglitazone, we're going to have a decrease in cardiovascular protection. Now, these are the standard of care from the American Diabetes Association in 2022. And for the first time, and I've been trying for, I don't know, over a decade to get the ADA to change their approach to combination therapy. There is a statement now in the standards of care, and I'm just going to read it to you. Because type 2 diabetes is a progressive disease, maintenance of glycemic targets with monotherapy is often possible for only 4 years, and I've shown you that data. Traditional recommendations have been to use stepwise addition of medications to metformin. This is the treat to fail approach, which we know doesn't work. However, there are data to support initial combination therapy for more rapid attainment of glycemic goals and longer durability of glycemic control. They quote two papers. The first paper is our paper, the EDIC study by Dr. Avdugani and myself. And the second is the Matthews Del Prado paper, the Verify study, which I showed you. So now what we've been talking about and what's been recently launched is this triple combination of pioglitazone, sitagliptin, and metformin. And I think I provide you with abundant evidence that each of these three drugs in and of themselves are very good drugs. And when you put them together as two agents, or even better, as three agents, you get major improvements in the A1C and durability of glycemic control. So if we now come back and end with the ominous octet, and we start here in the upper right, you can see we have the TZDs working on the adipocyte. TZDs and DPP4 inhibitors, DPP4 inhibitors working here on the gut. Both PO and DPP4 inhibitors augmenting beta cell function. DPP4 inhibitors inhibit glucagon secretion. All of the three drugs work on the liver. And pioglitazone is a very, very powerful insulin sensitizing drug. So we're correcting 6 of the problems of the ominous octet. It should not be surprising, therefore, that this triple combination is very effective. It's very cost effective because it's 3 in 1. And it's very easy for physicians to use. And because it's one tablet containing 3 different drugs, it's very easy for patients. So I'm going to stop at this point, and we'll ask our moderator to come back on to continue on with the program.
Wow. Thank you so much, Professor Ralph. It was indeed a mesmerizing talk covering all the aspects of insulin resistance, important mechanism of action of 3 drugs, especially focusing on pioglitazone, its unique mechanism of action, and a lot of other advantages that the drug is providing. Now, let's move on to the next part of our discussion. I would now request Dr. Vinayak sir to take us through the phase 3 study that is being conducted and submitted to the regulators in India, basis which this formulation has got approval. The study which is named as Impact Study. So over to Vinayak sir for his deliberation, please.
Thank you. One minute, I will just share my screen.
Professor Ralph, would you stop sharing your screen, please? Yeah, perfect. Yes. Done.
I still have to give. Are we okay? Yeah.
Yes.
Okay. Is it visible?
Yes, doctor. Visible.
Okay. Thank you. Thank you, Professor, for your wonderful talk. So I'll be taking you through this impact study where they studied fixed dose combination of sitagliptin 100 mg, pioglitazone 15 mg, and metformin 1000 milligram sustained release. So what is the rationale behind this triple therapy of sita, metformin, and pioglitazone? Just now, Professor has already explained what is the benefit of all this combination by combining all these 3 different drugs by having different mechanisms of action. They have the complementary glycemic control, and if you use the early use of this combined insulin sensitizer, it is shown that it preserves the beta cell function. It also postpones the need for the insulin injection. So these are also few candidates where we can use this type of triple drug combination. Each ingredient also used at the submaximal therapeutic dose to reduce the possibility of various side effects. And also the ingredients, they are there to prove the reduced cardiovascular complication of diabetes. And also all ingredients have once daily dosaging. And we all know that this patient compliance in Indian scenario, it's a very poor, and because of which there is a very poor glycemic control and diabetic complication. So in this study, you can see the appropriate adherence and poor adherence. So almost 38% patient had the poor adherence, and this adherence to the anti-diabetic drugs, which was found to be just 62%. And because of the increasing age, illiteracy, occupation, BMI frequency, and multiple dosage of drugs were significant factors. These are the responsible for the medication non-adherence. So this is one of the important factor why we are not getting the target HbA1c. And just now we have listened from Professor what are the various advantages of the fixed dose combination. Because of the progressive decline in the beta cell function, the oral anti-diabetic agents, they lose efficacy with prolonged usages, and progression from the monotherapy to the combination therapy may be necessary over the period of time. And the advantages of using fixed dose combination, like the dosage, it would be very simple dosages. It improves the therapy adherence and treatment outcomes. So that is one of the important factor to get the better HbA1c control. They are very, it reduces the medication error. It gives the synergistic action of the drugs in combination. It definitely reduces the frequency of administration, and this adherence brings the better clinical outcome. Therefore, it prevents the complication and hospitalization as well. These are the safer. It gives a safer, sustainable glycemic control. Also, there is a better long-term outlook, and it helps to prevent the beta cell function. It improves the insulin sensitivity. It reduces the pill burden, and ultimately, it improves the adherence and compliance is better. It also gives the better glycemic control and prevents the complication. So with this background, we'll discuss this impact study. It's a phase 3 multi-center randomized double-blind parallel group active control study to compare the efficacy and safety of fixed dose combination of metformin 1000 milligram sustained release, sitagliptin 100 mg, and pioglitazone 15 mg tablets versus Janomit XRCP, which is the combination of metformin hydrochloride 1000 mg and sitagliptin phosphate 100 mg in patients with type 2 diabetes. So the primary objective of this study was to compare the change from baseline HbA1c at 24 weeks between the fixed dose combination of this metformin, sitagliptin, and PO, and the combination of the metformin and sitagliptin in patients with type 2 diabetes. Whereas the secondary objective of this study is to compare the change in the body weight from baseline to end of study, compare the change from the baseline in fasting and postprandial plasma glucose, and to evaluate the safety and tolerability of the investigational product. So this is a study design. It is a prospective multi-center randomized double-blind double dummy parallel group active control study where the sample size was 236 and 118 in each group, including dropouts. And it was studied across the 20 different sites of India, where they included combination of government as well as the private hospital. 1:1 randomization was done. It was total duration of study was 10 months, whereas in which the recruitment period was 4 months and study period was 6 months. Screening was done for 4 weeks, including 2 weeks running period. Treatment duration was 24 weeks, and the dosage is given as a once a daily for 24 weeks. So this is a study flow chart. Initially, screening period was less than 4 weeks, including running period of 2 weeks, followed by randomization at day 1. Treatment was given for 24 weeks, in which test product versus the reference product, and the end of study was at 24 weeks. So the study results, if you see the efficacy point of view, the change in HbA1c at week 24 from the, you can see the baseline at visit 9 and 24, the LSM change from the baseline. In the test product, the HbA1c reduced to 7.56 from the baseline 9.21, whereas the reference that is only sitagliptin metformin combination, it reduces the HbA1c from 9.25 to 7.86. So the effective difference is 0.32. So the better HbA1c reduction with the PO metformin and sitagliptin combination. Fasting plasma glucose change at week 24, the test product that is PO, sitagliptin and metformin gives the better fasting plasma glucose reduction from baseline 136 to the reduction is up to 33 milligram per deciliter, whereas the reference molecule that is sitagliptin metformin from 160 to reduction is 15 milligram per deciliter. Same thing is there with the postprandial plasma glucose at week 24 with better reduction with test as against the reference from 58 to 35 milligram per deciliter. And we are more concerned of the body weight actually because the pioglitazone is there. But at this 24 week, there is no significant increase in the weight gain in the group who received the pioglitazone as against the sitagliptin metformin combination. As far as the adverse events are concerned, they are not significant in the test group who received the pioglitazone, sitagliptin, metformin. There are different parameters were studied like blood and lymphatic system disorders, anemia, thrombocytopenia, various GI disorders, abdominal pain, flatulence, gastritis, vomiting, metabolic and nutrition disorder, dehydration, hyperuricemia, and also the respiratory, thoracic, and medicinal disorder coughs. But there was no any significant increase in the adverse event. Those who were receiving the sitagliptin, pioglitazone, and metformin group. If you see the hematological parameters like hemoglobin, RBC count, platelet count, total WBC count at the time of screening and at the time of week 24. In the test and reference, there is no significant change in the hematological parameters. Biochemistry parameters like BUN, creatinine, EGFR, total bilirubin, AST, LT. So again, there is no significant change in the biochemical parameters if you compare from the screening to week 24 in the both the groups. The other biochemical parameters like a change in the ALP, creatinine, sodium chloride, potassium, amylase, lipase. Again, there is no significant change in all these biochemical parameters. Vital signs were also studied like pulse rate, systolic, diastolic BP, respiratory rate, body temperature. Again, there was no significant change in all these vital parameters. So to conclude, this test product of a fixed dose combination of metformin 1000 mg, sitagliptin 100 mg, and pioglitazone 15 mg tablet, it was found to be superior in combination to metformin 1000 mg plus sitagliptin 100 mg in terms of reduction in the HbA1c, fasting plasma glucose, and postprandial plasma glucose. And this test product also shown good safety and tolerability profile. So we have just professor has discussed this homogeneous octet and this various pathophysiological defect. And if you use this combination of pioglitazone, metformin, and sitagliptin, we could address the 7 out of 8 pathophysiological defects. So the possible patient's profile for this particular fixed dose combination, we can use this combination in patients with insulin resistance who are not controlled on the dual therapy, patients with uncontrolled diabetes, those who refuse to take insulin injections, those with the lean diabetics, and insulin-resistant type 2 diabetic patients having dyslipidemia, hypertension, or history of cardiovascular disease. So thank you very much. I will hand over session to the moderator.
Sure. Thank you so much, Dr. Vinayak, for taking us through the phase 3 study. And very soon it will be published and available for reading for everybody here. Now we can talk about, we'll take the questions. We have a lot of questions for Professor Ralph in the chat box. So we'll take it side by side, and we'll also take the panel discussion questions to our experts. So I request Dr. Vinayak, Dr. Subrata, and Dr. Himanshu sir to switch on their cameras and let us take few panel discussion questions. Now, first question to Dr. Himanshu is there. Dr. Himanshu sir, you are there? Okay, perfect. So the first question to you is about the pathophysiology of diabetes that Professor Ralph has already narrated. From triumvirate to now ominous octet, we have traveled a lot in terms of the pathophysiology of diabetes. So is our understanding is now complete? What are your views on the pathophysiology of diabetes?
Thank you, Professor Ralph, for an excellent and detailed lecture. And as a type 2 diabetes is increasing, we are finding many more physiological mechanisms. Right? So with triumvirate, it became octet, and in recent times, we have seen there has been a concept of dirty dozen. So it adds on to the dopamine, vitamin D, RAS system, and testosterone over to your ominous octet. And in recent 1 year, our group has also put up the criteria for Insulin 16. And beyond these 4 criteria, we have added melatonin, SGLT1 in the gut microbiota dysbiosis, and the increased renal gluconeogenesis. So now, what we can say is that the pathophysiology of diabetes is actually the opposite of open thread, right? So one thing does not explain it. It is more of a reconstructed. That is, we have to understand and try and find out different physiological management and to make actually, so the drugs that are available are only achieving for ominous octet as of now. And as the major pathophysiological are found out, we can have more drugs that counter that. So from my understanding, the final word regarding the pathophysiology of diabetes is yet to be written. We will see much more pathophysiological mechanisms coming up over the next few years as an understanding of the diabetes.
Sure. Thank you so much, Dr. Himanshu, for your opinion. And indeed, it's an evolving science where you never know. 10 years down the line, we could have different additional factors who can contribute to the pathophysiology of diabetes. Now, moving on to the from diabetes, this pathophysiology to now insulin resistance. So, I would like to take the opinion of Dr. Subrata here regarding the insulin resistance in India. How do we evaluate that insulin resistance on a clinical basis? Do we go for clinical evaluation in terms of the duration of diabetes and other factors, or we calculate the biomarkers for insulin resistance like HOMA IR in India, sir?
So from a basic understanding of the pathophysiology of type 2 diabetes mellitus, we now know that relative insulin deficiency put on top of insulin resistance forms the cornerstone of defect in type 2 diabetes mellitus. Now, insulin resistance by itself can be the driving force behind both development and progression of type 2 diabetes mellitus. Now, the relative contributions of these two entities in the genesis of type 2 diabetes mellitus might vary according to ethnicities, and this variation being encompassed being the recently published 5-cluster classification of type 2 diabetes mellitus, like severe insulin resistant diabetes, severe insulin deficient diabetes, severe autoimmune diabetes. And preliminary studies suggest that a significant proportion of Indian diabetics might harbor this severe insulin resistance phenotype. So natural question hovers in our mind, shouldn't we be quantifying insulin resistance in our Indian diabetics? Now, as tempting it might sound, please remember that insulin resistance is evaluated during HOMA-IR model, but this facility is usually available in tertiary care settings and research labs, at least in this part of the globe, and not available even in tier 2 cities, and definitely not in far-flung areas and low resource settings. So a more pragmatic and cost-effective approach would be evaluating insulin resistance by surrogate clinical markers like central obesity, skin tags, acanthosis nigricans, and some easily performed basic lab tests like UST documented non-alcoholic fatty liver disease, polycystic ovarian morphology, high triglycerides with HDL, and reserving the usage of HOMA-IR models to clinical dilemmas where we are in difficulty regarding typing of diabetes mellitus, or to clinical trial settings. So in a nutshell, for every average case of pre-diabetes or type 2 diabetes mellitus, opt for clinical evaluation of insulin resistance or perform basic lab tests for finding out more about the same. And in case of clinical dilemmas or the academic interest, opt for HOMA-IR model. That would ensure a more judicious usage of resources in a resource-constrained country like India. That would be my take. Thank you.
Thank you, sir, for your opinion. Indeed, clinical parameters definitely are important to be evaluated, and biomarkers are also in certain cases. Now, the next question, again, I'll pose it to Dr. Subrata before I go to Dr. Vinayak, is regarding the question that I just posed to Dr. Ralph as well. That in India, it is always people start with metformin and sulfonylurea combination, which is glimepiride. So, with the advent of newer drugs, powerful drugs like SGLT2s and even DPP4s, do you feel the sulfonylurea and metformin is still relevant in Indian market, or it is now time to go to different combination as a dual therapy as well?
So Dr. Ralph is already here. Now, ADA in a joint collaboration statement with EAST in 2019-20 mentioned that when the starting A1C is more than equal to 1.5% above the target A1C, opt for two anti-diabetic agents simultaneously, even in treatment-naive, newly diagnosed TPM patients. And sitting in tertiary care institutions in India, we routinely encounter patients having an A1C more than equal to 8.5%. Now, most of the global guidelines advocating the standards of care in the field of type 2 diabetes mellitus mention diet and lifestyle modifications with metformin as the center stage of treatment. So metformin remains on board in most of the treatment algorithms of type 2 diabetes mellitus until and unless there is an issue of metformin intolerance or contraindications to the using. So the real question we should be asking is that what should be the ideal partner with metformin as first-line therapy in type 2 diabetic patients in India? Now, standing in 2023, a molecule like sulfonylureas with known hypoglycemia risk, with known weight gain risk, no cardiorenal benefits, no pleiotropic benefits, no documented effects on the amino octet defects in type 2 diabetes mellitus is simply not acceptable. There is no compelling need to use sulfonylureas as first-line therapy with metformin when better alternatives like SGLT2 inhibitors with proven cardiorenal benefits and DP4 inhibitors with GLP-1 receptor analogs with documented effects on the amino octet defects in type 2 diabetes mellitus are easily available, particularly after the off-patency of majority of the gliptins and dapagliflozin. Now, the only scenario we can think of is a low resource settings where affordability of patients and availability of gliptins and or SGLT2 inhibitors might also be a concern. So herein the usage of sulfonylureas with metformin might be a reasonable option when we remember that these two molecules are included in the national list of essential medications. The other possible scenario I can think of is a potentially hypothetical one when there is resistance or when there is intolerance or contraindications to almost all the first-line therapies in type 2 diabetes mellitus, barring metformin and sulfonylureas. This can be another area where you can consider the usage of sulfonylureas with metformin as first-line therapy. Other than that, in the age of gliptins, in the age of GLP-1 receptor analogs and SGLT2 inhibitors, we should never consider sulfonylureas with metformin as first-line therapy. That would be my take. Thank you.
Wow, it's very clear and straightforward answer with evidence-backed science there. Thank you, Dr. Subrata, for this. Now, let us go on to again Dr. Himanshu and ask him about pioglitazone. And Dr. Ralph extensively spoke about pioglitazone. So, do you believe, Dr. Himanshu, it is pioglitazone is a forgotten, cost-effective medication which is cardioprotective and can hamper the pleiotropic benefits to the patients of type 2 diabetes and still very, very relevant for our country?
Definitely. Because see, when we started with the medicine, pioglitazone used to rule the roost, right? It was one of the preferred drugs. Somewhere down the line, because of the perceived incidence of bladder cancer and increased edema, the use of pioglitazone quite reduced by the time we went into medical practice. Though we had a multitude of trials showing the CV safety, as Professor Ralph has already gone into depth about the IRIS and the proactive trials. We have major other trials such as Periscope and the Scamper trials, which actually show the active reduction in the carotid atherosclerosis. So definitely this is a drug that actually provides the CV benefit and has gone out of tune maybe because of the perceived edema and the weight gain, which is actually not much. So with respect to the CV benefit, it should be one of the preferred drugs. I've used it in patients, young patients also. Recently also, I had a patient coming to me, 22 years old, already a history of coronary atherosclerosis. He was on 140 units of insulin and every other OAD known other than the pioglitazone. But once we started him on pioglitazone, there was a significant reduction in the insulin requirement. And this is very important because this is an insulin sensitizer. And there is a definite improvement in the CV risk because it has a pleiotropic effect. It reduces the lipid profile, it improves it. There is decrease in the HbA1c, NASH improvement. The procoagulant factors such as PAI are also reduced, hyperinsulinemia is reduced. All of this is shown in the diabetes management and CV safety. So yes, pioglitazone had gone out of favor in past 10 years, but we are seeing the resurgence now with more data that is coming up on safety.
Sure. Thank you so much, Dr. Himanshu. Now let us move on to Dr. Vinayak for a series of 2 questions. So Dr. Vinayak, first question to you is about the percentage of patients in India who will require the triple therapy. Obviously, we have the patients who on dual therapy, they are not responding. So in your opinion, what could be the percentage of patients who may require this triple therapy? That is first question. And secondly, that what could be the ideal patient profile in your opinion for this triple drug combination to be used in India?
Okay, so regarding the percentage of patients requiring triple therapy, so I'm not aware of the particular studies or trial in India, but according to my clinical experience, as I practice in the tertiary care center kind of setup, so I mostly get the referred patient, those who have already being treated by like treat to fail approach, initially one drug, then two drug. But in my opinion, almost for 40 to 50%, almost half of them they would require the triple drug therapy. It might be SGLT2 inhibitor, a DPOR inhibitor, metformin, or this is a newer combination, obviously. So I do not have that much of data of using 5 liters on metformin or DPOR inhibitor. But in general, this triple drug therapy after addition of two drugs, if they are not getting the adequate HbA1c, so this patient number goes almost maybe 50% or beyond that also in my clinical practice. And regarding your second question, those patient who probably get benefited with this FDC of 5 liters on metformin and sitagliptin. So in those patients with the insulin resistance, those which are not controlled on the dual therapy, then the patients with the uncontrolled diabetes, those who refuse to take insulin injections, patients with the lean diabetics, and insulin resistance type 2 diabetic patient, those who have dyslipidemia, hypertension, or history of cardiovascular disease.
Right. And indeed, the second point that you mentioned about the patient who are not controlled on dual therapy, yet they refuse to take insulin injections. There are certain patients where they don't want to take insulin, and they'll be happy to take triple drug combination.
Thank you.
Right. Okay. So we have a couple of questions in the chat box. I will read it out, and Professor Ralph probably could throw some light on that. Pioglitazone we spoke about. Is it safe in the patients who are older than 60-65 years? What is your experience regarding the age and the safety of pioglitazone?
Yeah, so we actually we published a paper on this about 5 years ago. So we have a very large gerontology center. Actually, it's NIH funded, one of the largest in the United States, and we specifically did a study in elderly people, meaning over the age of 65 to 70. And we didn't go above 30 milligrams. You get, say, 85 to 90% of the efficacy of pioglitazone when you're at 30 milligrams. And what we showed is the drug was really quite safe, quite effective. We did not see an increased incidence of side effects. And I might also point out that in the IRIS study, which I showed to you, the people who had who got in because they had a previous stroke or a TIA, Dr. Abdul Ghani and I, along with Dr. Inzucci, we did a post hoc analysis and looked at the 3 doses that people were on in that study, 15, 30, and 45. And you got the same cardiovascular protection whether you were on the 15, the 30, or the 45 milligram dose. So in my practice, I would say I almost never go to the 45 milligram dose. And if I'm going to the 45 milligram dose, it's always in combination with a GLP-1 receptor agonist. So in terms of your triple therapy here, where you have the 15 milligram dose, that would be very, very safe in the elderly population. In fact, I think you could even give 2 tablets if necessary, and it would still be very safe.
Perfect. Okay. Now, again, the second question is revolving around pioglitazone, and it is regarding weight gain. So, obviously, if there is a weight gain, can you use this drug in obese patients also, obese diabetics? And how much percentage of weight gain is expected in those patients in terms of kgs?
Yeah, so as I tried to point out, and I know this seems very strange, but it's true. The more weight you gain, the less likely you are to die. The more weight you gain, the greater the improvement in insulin sensitivity. The more weight you gain, the greater the improvement in beta cell function. So no matter what you want to look at, the more weight you gain, everything gets better. And that's very, very paradoxical, of course. So how does that happen? So PPARs, pioglitazone, you bind to the PPAR gamma receptor, and then all of these very good cardiovascular and metabolic benefits occur. Now, in addition, in the brain, the highest density of PPAR gamma receptors are in the hypothalamic area. So when I put you on a PPAR, I activate those PPAR gamma receptors in the brain, and that stimulates your appetite. So there are two things that are going on here. When you take the drug, you're going to stimulate those PPAR gamma receptors in the brain. You're going to gain weight. And then all the other metabolic effects are occurring through PPAR activation in muscle, fat, in the heart. And these things are occurring in parallel. So it's not that the weight gain is making everything better. It's you're gaining weight is telling you that you've acted PPAR in the liver, in the muscle, in the adipocyte. And that is why the weight gain parallels and showing you the benefit of the drug. Now, I know that no one wants to gain weight. Okay, cosmetically, that's not good. But the only negative part of the pioglitazone is a cosmetic issue in terms of the weight gain. It's not a metabolic or cardiovascular issue. That's a very difficult concept to get across to people, because we all know when you overeat and you gain weight and you're not on pioglitazone, things get worse. But you see just the opposite with pioglitazone. So when you put people on pioglitazone, it's very, very important that you tell them that their appetite is going to be stimulated. That's the effect in the hypothalamus. And so they need to conscientiously recognize, hey, look, my appetite's going to be stimulated. I have to be careful. I have to be careful not to overeat. But even if they overeat, it's not going to hurt them. Cosmetically, they may not like the way they look in the mirror, but from the metabolic and cardiovascular standpoint, it is not going to hurt them. And as I said, in the United States, the way I get around this issue is I combine it with a GLP-1 receptor agonist. And once you put pioglitazone with a GLP-1 receptor agonist, then you completely block the weight gain. In fact, you get a lot of weight loss because of the GLP-1 receptor agonist. But that's a very different story. You can't combine a GLP-1 with your triple therapy, because DPP-4 and a GLP-1, they're working through the same mechanism. And then you defeat the purpose of giving an injection, as what you want to do is to get people easier to take the triple therapy medicine for convenience.
True, sir. And in fact, one of the next question was regarding any thoughts on the usage of DPP-4 and GLP-1 together. I think you addressed just now in terms of their mechanisms.
Yeah, there's no sense of putting them together. We actually have done that study, as has others. There's absolutely no benefit of putting a DPP-4 inhibitor with a GLP-1 receptor agonist, because they're basically working through the GLP-1 axis. So you won't get any benefit of putting them together, and it costs patient more.
Yeah. And Professor Ralph, in your opinion, the ideal patient profiles for this particular combination?
I would say virtually anybody. Quite frankly, 100% of diabetics are insulin resistant. Okay, so pioglitazone will always be indicated. There's always a deficiency of beta cell function, and so the DPP-4 inhibitors are working on your beta cell. And there's always insulin resistance in the liver and overproduction of glucose by the liver. So metformin will always be indicated. So to me, I think this is a very nice combination to start with, because all of these defects are present in your diabetic patients. So I really wouldn't limit it to anybody. The exception might be, the very elderly person. If you have a 80 or 85-year-old person and the A1C is 7.5 or 8, I don't think they need to put them on triple therapy. Probably, single dose of a DPP-4 inhibitor or metformin. Always keep in mind, do no harm. So in elderly people, safety, is a big issue. And, if you're 80 or 85, how much longer are you going to live? You're not so much worried about complications and tight control in these people. But in any relatively young, middle-aged person, I think that the triple combination therapy that you're talking about would be a reasonable approach to start with.
All right. Great to hear your views, Professor. And I think we are just about to finish our timeline, and we have completed our questions as well. So you beautifully narrated about the patient profiles, the pioglitazone pleiotropic benefits, the clinical studies, and our panelists also had nicely explained about their views in terms of insulin resistance and this triple drug combination as well. So it's time to wrap it up, this session. And I would like to thank, first of all, Professor Ralph for his valuable time and absolutely precious insights on diabetes and insulin resistance. It's always a pleasure to have Professor on this forum, and we are looking forward to collaborate for further meetings. I would like to thank our three speakers, Dr. Himanshu, Dr. Vinayak, and Dr. Subrata, for their time and valuable opinions. And I would like to thank all attending doctors who had invested their Friday evening today and learning some very good insights on diabetes management. I would like to hand over session to my colleague Prashant for word of thanks for next 2 minutes, please.
Thank you, sir. So, a very good evening to one and all. On behalf of Alkem, I, Prashant Rane, would like to thank you to Dr. Ralph Differenzo, sir, Dr. Subrata Banerjee, sir, Dr. Vinayak Harade, sir, and Dr. Himanshu Sharma, sir, for excellent session. Would like to also thank you, Dr. Mayur, for facilitating this session very, very well. And I'll be failing in my duties if I do not say thanks to our most important part of today's symposia, which is none other than the distinguished attendees, because these you are the sole purpose of this meeting. Thank you for your all active participation, which made Symposia is a great scientific session. Thank you very much, and have a great evening ahead, and happy weekend to everybody.
Okay, it was my pleasure to be with you. Thank you very much for inviting me.
Thank you, sir. Bye-bye.
Thank you, sir.
Okay, bye-bye. Ciao, ciao.